Hello, my name is Kelly Smeester. I'm a physician assistant at South Denver Gastroenterology. I just gave a podcast on non-invasive liver disease testing, and today we're going to be discussing monitoring MASLD in type 2 diabetes patients. I did previously work in endocrinology, so it's helpful to have that background to be able to provide some insight into this. So given the high prevalence, what is the practical and evidence-based approach for ongoing monitoring and surveillance of MASLD and MASH developments in patients already diagnosed with type 2 diabetes, but initially deemed low risk? Thankfully, we have a lot of tools that we can use for non-invasive testing to help guide us and stratify these patients. With a high prevalence of diabetes and obesity, it is important that we have practical and quick tools that we can help determine if these patients may be at risk. I recommend starting with the Fib4 because it's easy to calculate with labs that we are already routinely ordering. It's a measurement of the age, AST, ALT, and platelet count. And there are online calculators that are very easy to use where we can get this value very quickly. It has a high negative predictive value, so it helps us rule out advanced fibrosis relatively quickly. And then if patients fall into the indeterminate or high-risk categories, then we can advise them to get additional testing, whether that's a ELF score, which is a marker for fibrosis in the blood, or to measure something like a FibroScan or an MR elastography. But the Fib4 is a really great place to start. There are some limitations. It is less accurate in patients less than 35 or greater than 65. And so those are some difficulties. Also has a 30% indeterminate rate. So that means that a lot of patients do fall into that indeterminate category, and sometimes we'll need additional testing. But overall, it's an excellent place to start. And you may wonder, how frequently should APPs reevaluate fibrosis risk using, say, the Fib4 in their type 2 diabetes population? And how might we consider prompt assessment if we have concerns? So I recommend annual assessment of the Fib4. Like I said, it's very easy to calculate. I recommend that it be added to the checklists of other things that we follow in our diabetic patients, like eye exams, foot exams, that kind of thing. And then triggers to prompt earlier reassessment would be if there's been a change in the lab values, like a significant change that raises suspicion, or if they were borderline on their previous check, it might be a good idea to consider rechecking it in 6 months instead of waiting the full year. And another point of discussion is the role of routine LFT monitoring versus using these non-invasive techniques for calculating liver disease progression. And my argument is that it is very important that we not just rely on the LFTs, because in our diabetic population, there's a degree of LFT abnormality more than the general population. Specifically, ALT can be elevated in this population. And other things like medications might elevate their LFTs. And so LFTs alone may not give us a great measurement of what their fibrosis risk is. So using the non-invasive tools like we talked about, the Fib4 or FibroScans, they give us the ability to be able to determine if there might be more going on, especially in our patients who are otherwise asymptomatic. They may not be presenting with anything specific or anything concerning, but by doing the Fib4 or a FibroScan, then we can assess them and their risk. So I definitely feel like it's a great tool, especially doing like FibroScans. They can not only determine the stiffness of the liver, but the steatosis, or how much fat has infiltrated into the liver. And this is a really important point because a lot of people have fatty infiltration, and that may even be severe, but they're not showing any signs of stiffness. And this is a very important time where we can intervene and try to help them make lifestyle changes, modify their diet, lose some weight, all of this, which can help then prevent them from progressing towards fibrosis. And it's important to keep in mind that all of these are various tools and should be used in combination. So not one of them is absolutely diagnostic. Certainly liver biopsy has historically been the gold standard, which we rarely use anymore. So it's nice to have these other tools that are much less invasive. And how can APPs leverage the type 2 diabetes care setting to integrate patient education about MASH risk and the importance of lifestyle interventions for liver health? And as I just discussed, there's a lot of opportunity in these type 2 diabetic patients because they are already maybe mindful of their diet, and it's an opportunity for us to discuss that with them. But working in an endocrinology practice in the past, I recognize the responsibilities APPs have in these settings to manage these complex patients. There are many parameters that we are keeping track of: their blood pressure, their kidney health, their heart health, their eye exams, making sure they're getting their foot exams, all these different things. So to add one more thing to their plates, to be monitoring for MASH risk and fibrosis of the liver is a lot. And that's why, like we talked about earlier, using the simple tool like the Fib4 can be very helpful, takes that burden off of them. And I would argue that it would be wonderful if this Fib4 could even be integrated into EMRs. And so this calculation could already be done, not something the provider has to spend time doing on their own, but the calculation comes through and then flagged if elevated, which would then prompt the provider to consider additional considerations. In addition, diet does play a major role. And as I said, we are capturing these patients anyway because diabetes has a strong correlation with diet as well. And so many of the same dietary recommendations apply to both diabetics and patients at risk for MASH. And this includes, trying to limit carbohydrate intake, trying to avoid processed foods. Even modest amounts of weight loss can help both glycemic control as well as reversing MASH trends. So overall, the type 2 diabetes care setting is a great place to try to capture some of these patients who otherwise might not be aware that they are at risk for liver disease. Thank you for joining us and spending your time here learning about MASH and how we can address it in the type 2 diabetes space.